to view the things we sent out notice. Okay. So sometimes I didn't want you to worry too much, but you can still call and say, hey, I got this update. You know how you can do that, right? Yeah. Are you moving? Yeah, I was.
Hello, everyone, and welcome to the 6th webinar in our FY 2019 webinar series titled SOAR Medical Summary Report Summer Writing Camp. My name is Kristen Lupfer, Project Director of the SAMHSA SOAR TA Center, and I will be your moderator today. Before we begin, just a few housekeeping items to review. This training is supported by the Substance Abuse and Mental Health Services Administration, or SAMHSA, and the U.S. Department of Health and Human Services. The contents of this presentation do not necessarily reflect the views or policies of SAMHSA or DHHS. The training should not be considered substitutes for individualized care and treatment decisions. As a reminder, your lines will be muted throughout the entire webinar. The webinar is being recorded and will be available for download on the SOAR website soon after. You may download the presentation slides and other materials now by going to the top left of your screen and clicking File, Save, Document, or you can visit the SOAR website at soarworks.prainc.com. Click Webinars on that left sidebar and you can choose today's topic. If you'd like to follow along with closed captioning, you can open the multimedia viewer on the bottom right corner of this WebEx application and select high contrast if you have any visual challenges. At the conclusion of the webinar, you'll immediately see a brief evaluation, which we kindly ask you to complete. And finally, we'll save all questions and comments until the end of the presentations, at which time we will review instructions for posing questions to the panelists via the Q&A box. So it's our intention that by the end of this webinar, you will understand why it's important to include an MSR with your SOAR-assisted SSI or SSDI application, what information is relevant to key sections of the MSR, and how to write quality MSRs and get them reviewed with feedback prior to SSI submission. So to reach those objectives, we'll begin this afternoon with presentations from Dan Coladonato, a project associate here at the SAMHSA SOAR TA Center. We'll hear from Jennifer Ankton, the Disability Adjudication Supervisor with the Nevada Bureau of Disability Adjudication in Las Vegas, and Sean Kostick, the Client Financial Services Manager and SOAR Local Lead at Pittsburgh Mercy, will share his experience or medical summary reports. And then finally, we'll have plenty of time for questions and answers facilitated by the SAMHSA SOAR TA Center. So providing today's welcome today is Dr. Mark Jacobson, SOAR Project Officer and Public Health Analyst in the Office of Program Analysis and Coordination at the Center for Mental Health Services in Rockville, Maryland. Mark?
All of you joining us today. On behalf of SAMHSA and the Homeless Programs Branch of the Center for Mental Health Services, I would like to welcome you to this SSI-SSTI Outreach, Access, and Recovery webinar called SOAR Summer Medical Summary Report, MSR, Writing Camp. As many of you know, SOAR helps states and communities increase access to Social Security disability benefits for eligible adults and now children and youth who are experiencing or at risk of homelessness and have a serious mental illness, medical impairment, and or a co-occurring substance use disorder. Today's webinar will focus on how to write quality MSRs and why it's important to include an MSR with your SOAR-assisted SSI-SSTI applications. I'd also like to welcome and thank our presenters, Dan, Jennifer, and Sean, for your willingness to share your expertise with us. I'd like to turn it back over to Kristen, who will be moderating our webinar today. Kristen?
Thank you, Mark. All right, so Dan Coladonato is going to kick things off with an MSR overview and new findings on its effectiveness. Dan?
All right, thank you, Kristen. Welcome to everyone that's attending today. It looks like we have almost 500 people attending, so that's really great to see. I'm also really happy to be joined by Jennifer and Sean and to get perspectives from the field and also from DDS. So I'm going to go over the medical summary report, what's in it, why it's important, and go over some statistics that we've found about its effectiveness when used with SOAR-assisted SSI and SSDI claims. So the medical summary report is really a letter which describes the individual that you're working with, the individual that is experiencing homelessness and has a disabling health condition. It also describes their limitations in functioning associated with those either mental or physical health impairments. The medical summary report will support the medical records that you collect and submit with your SOAR-assisted SSI or SSDI claim. It doesn't replace the medical records, but it supports and summarizes and highlights the most important parts of those medical records for DDS to examine. Like I mentioned before, it provides a clear link between the applicant's conditions and their functional limitations. In some communities, it can take the place of the SSA 3373, which is the function report. And this is the form that you probably see come to you as the person's representative and also to the claimant or the applicant. Once the case gets transferred to DDS, this report will get sent out. And because the medical summary report covers everything that's included in this report and usually a lot more, it can sometimes take place of this form. The medical summary report also becomes medical evidence as part of the claimant's file at DDS and SSA when it's co-signed by what SSA considers an acceptable medical source, and I will go over what those acceptable medical sources are later. The medical summary report can be sent directly to the DDS examiner assigned to the person's claim, or it can be hand-delivered to SSA when you deliver the additional SSA forms that you're submitting as part of the SOAR process. And essentially, the medical summary report is answering the question, can this person work and earn substantial gainful activity despite their conditions that they're experiencing and the resulting functional impairments. So at the SOAR TA Center, we have a really helpful tool available for you to use. This tool is especially helpful if you don't have experience writing reports like the medical summary report. Some people might have experience writing behavioral health assessments as part of your clinical practice. But if you're not a clinician and this is your first time really writing one of these reports, this medical summary report interview guide and template can be a really, really helpful tool for you to use when you're getting started writing these reports. So we have this will be available, as Kristen mentioned. You can download it as part of today's presentation. It's also available on our SOARworks website in the library and tools section at the top of the homepage of the website. So this tool really, it's used to help you gather information that's needed to write the medical summary report. It provides all the potential questions that you can use as a guide when you're interviewing your applicant. And it covers all the different components of the medical summary report and what to include for each component. And it gives you questions that are geared toward the person's functional limitations, which is really one of the most critical parts of the MSR is to include those functional limitations and how that person struggles to function day to day. So the questions are geared, the context of the questions are geared towards the individual's ability to work, like I said, at the substantial gainful activity level. It also provides you with questions to distinguish between a person's access and ability. And what we mean by that is if someone's experiencing homelessness and they're reporting that they're unable to cook for themselves, is that because the individual is living on the streets and doesn't have access to a kitchen? Or is it literally that they're not able to, they don't have the necessary skills to prepare and cook meals for themselves? Another example is if a person's reporting that they can't take public transportation, is that because they don't have the money to take public transportation, or is that because they get so overwhelmed when they're on a bus, when they're experiencing their mental health symptoms and they're unable to successfully navigate public transportation to get to work or to medical appointments or wherever else they need to go? And we strongly encourage you to use this tool, and the template itself will help you organize and write your MSR and make sure you're covering all the different areas that the medical summary report includes. So we just have some general tips for writing the MSR as well. We suggest that you begin collecting medical records for the individual that you're helping with the SOAR application almost immediately, if that's possible. Depending on the person, it might take a few rapport building meetings for you to have them sign the releases of information to start collecting their medical records. But the sooner that you can get those releases and request those medical records, the better, because having these medical records, a complete set of medical records, will make it a lot easier to begin writing the medical summary report. We recommend that you go through all the medical records and organize them in chronological order. This will help you to really start to see the onset of the individual's conditions, either mental or physical, and how they have affected their functioning from when they started to experience the symptoms and the conditions to the current date. We also recommend setting aside blocks of time to begin writing the report with no interruptions, and sit down with all the information that you need in order to write the medical summary report, which includes the person's medical records, like I stated. If there's an intake packet that you have with your SOAR program that gets sent to you with a referral for a SOAR application, and your medical summary report interview guide. So here are the different components contained within the MSR, and I'm going to go through each one of these components and talk about what should be included in each of the components. All right, so the introduction section. So within the introduction section, one of the most important things that you want to include in the introduction is any diagnoses or conditions that the individual has or has been diagnosed with currently or in the past. So this will give DDS an idea of what they're going to start looking for in terms of does the individual meet one of the SSA Blue Book listings, the listing of impairments. Within the introduction section, you'll also want to include the person's demographics, a physical description, any unique characteristics of the person, and then also your observations as the SOAR case manager. How does the person present when you're meeting with them? Do you observe any symptoms of their mental illness or their physical impairment? This will really help DDS to begin to see the individual as you do. You're going to probably have a lot of contact with the individual over the course of the time that it takes you to complete the application. So you'll want to include your observations of that person's symptoms, their mannerisms, and their behaviors. And then the personal history section of the MSR, this will include childhood and family information, education, and legal history. And I know Sean's going to also cover this a little bit during his presentation. However, just want to touch on a few different things here. In terms of the childhood and family information, you don't really, excuse me, you don't have to necessarily tell the person's entire story. You want to basically include information within this section about how their childhood and their family background relates to any current diagnoses or functioning. If you are going to explore the person's trauma, if they've experienced trauma and have subsequently been diagnosed with an anxiety disorder like PTSD, you would want to include, you don't have to go into great detail about the trauma, but you can just include it that they did experience that, and how did that affect them over the years, and how does that affect them currently in terms of their functioning and the symptoms that they experience. With someone's education, you want to include what the last grade they completed, any struggles or symptoms of their diagnoses while they were in school, were they involved in special education, did they have an IEP? You would want to include that relevant information. And then with the legal history section, a brief overview of the legal history. You don't have to necessarily include if a person has an extensive legal history, you don't have to include every time they were incarcerated or the dates of incarceration, that kind of thing. But we want to include any connections between the person's symptoms and contacts that they had with the police. So if an individual is homeless and is experiencing active psychosis and has continued interactions with the legal system and oftentimes gets taken to jail instead of maybe taken to the hospital, that would be what you would want to include in there. And also, if a person did receive psychiatric treatment while they were incarcerated, you want to include the dates and the provider and the information about the treatment they received while they were incarcerated. The employment section of the MSR. So this is a really important section to be as thorough as possible. I know oftentimes if an individual is homeless and hasn't worked in quite a while, it can sometimes be challenging to gather this information, but you want to be as complete and as thorough as possible when you're documenting the employment history. You want to describe the person's past jobs, including how long they stayed at each job, the different tasks they performed, and any struggles that they had at work, and why they left. Those are all really important to include. And also, how can you connect the difficulties that they had on their jobs with their mental health symptoms and other health conditions? Because remembering that in order to meet criteria for Social Security disability, an individual not only has to have a disabling health condition, but it has to severely impact their functioning level. So connecting their difficulties in maintaining work with their mental health symptoms is crucial. If you are able to contact former employers, that is extremely helpful, and you can include quotes or a written statement from the employer, and also include quotes from the applicant that you are serving and helping to submit a SOAR application. You would also want to include an overview of their military service if the person is a veteran. So the substance use and co-occurring disorders section of the MSR, this one is always, or not, I shouldn't say always, but it can be very challenging if the individual has been homeless for a long time, maybe has a spotty treatment record, and also has a co-occurring disorder. So the way DDS looks at cases where the person has a substance use history and a co-occurring disorder is that if the person's substance use is deemed to be material to the person's disability, the benefits will be denied. However, the determination does not necessarily require that the person be sober at the time of application. However, it's important to understand what is meant by materiality. So if a person is clean and sober and their functional impairment does not exist, they would not be, while they're clean and sober, the person would not be considered disabled. So essentially, if a person is experiencing severe depression while they're drinking alcohol, and then they stop drinking alcohol and their depression symptoms go away, that person likely would not be considered disabled by Social Security's rules. If a person is experiencing active psychosis while they're using stimulants, and they quit using stimulants and they're sober for a period of time and their psychosis goes away, likely that person would not be considered disabled by Social Security's rules. And like I said, I know this can be, I've done a number of SOAR cases myself. Oftentimes the cases that I have helped with, the individuals did have co-occurring disorders. So it can be challenging. However, if you are able to talk to the person about any periods of sobriety that they've had, were they hospitalized for extended periods of time, were they in long-term psychiatric treatment, were they incarcerated for periods of time, did they go to any substance abuse treatment programs, and if you can try to talk to the person about that, get dates and get those records, and use those records to try to document if the person still had severe symptoms of their mental illness while they were during these periods of sobriety. right, and the physical and psychiatric health treatment sections. For these sections, if an individual doesn't have a physical health condition, obviously you wouldn't need to include that section. But if they do, you want to definitely discuss any diagnoses that the person has been that has received over the years and current, and also give a brief picture, a chronological treatment history for the individual, both with physical health diagnoses and psychiatric health treatment. You would want to include specific quotes from the applicant and their medical records that illustrate their symptoms, any observations of their behavior, both from you as the SOAR case manager and also from all the treating providers. So what I would do when I was writing medical summary reports and covering these topics is I would go through the medical records and make sure that I include, for each treating provider, include what the diagnosis was that was assigned, what the symptoms are that was observed, and also what treatment that was provided. And if it's in the medical records, how the person responded to that treatment. Did their symptoms get better? Did they seem to function better while they received that treatment and after they received that treatment? Or did they not respond well to the treatment and their symptoms persisted? That would be the information that you would want to include in these two sections here. And durational issues, what we mean by that is how long has either the physical health or the psychiatric health diagnoses, when was it established and how long has it persisted? And if there's anything in the medical records about how long it's expected to persist. So is it expected to last 12 months or more? That would be something you would definitely want to include in these sections. And also a current mental status exam. DDS is for mental health cases. DDS is looking for a mental status exam within the last 90 days. So information about functional limitations. This is arguably one of the most important parts of the MSR to make sure that you're covering completely and thoroughly. For mental health cases, there are 4 areas of mental functioning that DDS will be looking at to determine whether the person has either marked or extreme limitations in those 4 areas. Within those areas, you'll also want to discuss any effects or side effects of the medications that the individual is taking and describe any supports that the applicant receives and compare those with lack of support. So for me, this came into play a lot when I was writing medical summary reports because I worked for an assertive community treatment team, and we provided a very high level of community support to the individuals that we served. We would sometimes see them 5 days a week, 3, 4, 5 days a week. And we would provide them a lot of support everywhere from monitoring their medications to taking them to community appointments to trying to help them get back into work, just a full range of services. And what I would find is when I was writing the medical summary reports, when I'm looking back at records before they got into our program, they appeared to function at a much higher level with that extra support that we provided compared to when they first came into our program. So it's important to note what the person's functioning looks like with extra support that they're receiving from either a community-based service or a family member or a friend. All right, and here are the 4 areas of mental functioning that will be examined by DDS for mental health claims. They are understand, remember, or apply information, interact with others, concentrate, persist, or maintain pace, and adapt and manage oneself. So under understand, remember, or apply information, this includes a person's memory, a person's ability to follow instructions, either written or oral, a person's ability to solve problems, simple or complex. Under interact with others, this involves an individual's ability to get along with others on the job, at home, in the community, etc. A person's ability to manage their anger or frustration when corrected at work or when given guidance or suggestions. A person's, if there's any avoidance behaviors or isolative behaviors that the individual is engaging in, that would be the information that you would want to include in interact with others. And then concentrate, persist, or maintain pace. This includes a person's ability to complete tasks, focus on details at work, at home, in the community, a person's distractibility at work. You would also want to include in this section if a person's able to, not only if they have concentration issues, but also are they able to persist with tasks? Are they able to, if they're working a job where even though the tasks are simple involved in the job, are they able to persist and complete those tasks and maintain the appropriate pace over an 8-hour workday or a 6-hour workday, whatever their previous work schedule included. And adapt or manage oneself. This is a person's ability to attend to their hygiene, respond to change appropriately, regulate their emotions appropriately, set realistic goals for themselves, etc. There used to be an area of mental functioning that was just activities of daily living and an individual's ability to complete those activities of daily living, but they are now considered throughout all these 4 areas. So you can include any functional limitations within these 4 areas as it pertains to activities of daily living. So within each of these 4 areas, you want to make sure that you try to include as many examples as possible of the functional limitations that the individual is experiencing as a result of their disabling health condition. In order to meet criteria for SSA disability, the person would have to either have marked limitations in 2 of the 4 areas or extreme in 1. So the more examples of their functional limitations within these 4 areas that you can provide, the better for DDS. And the last section of the MSR is the summary and contact information. This will tie together all the information that you've previously provided for a concise picture of the individual. Some people like to restate the diagnoses here and just a nice, just 1 paragraph summary conclusion. You'll also want to include your contact information as the SOAR case manager, so the DDS adjudicator knows who to contact if they have any questions about the report. And then also if you're able to have it co-signed by an acceptable medical source. And you can see here on the slide what's considered an acceptable medical source. That would be a physician or a PhD psychologist, PsyD psychologist, nurse practitioner. There's a few different categories of advanced practice registered nurses, a physician's assistant, or an audiologist. All right, and I also just want to mention that we have a number of MSR examples on our website. This is also in the library and tools section of the SOARworks website. And as you can see listed here, there's pretty much every mental health diagnosis that you might encounter. I'm sure there's not every single one on there, but there's a lot of them that you could review if you're working with an individual that has schizophrenia. You can review that medical summary report. And also, as you're getting started with your medical summary reports, or even if you've already submitted a few, if you want some extra support, you can send redacted medical summary reports. Just remove all the personal information of your client, and you can send that to us at the SOAR TA Center, and we can review those and provide feedback upon request. So don't hesitate to use that support if that's something you feel you need. And the last thing that I want to talk about is the effectiveness. So the medical summary report it's definitely the longest thing that you'll have to do as part of the SOAR application. It does take time collecting the medical records, going through the medical records, writing the medical summary report can be a lengthy process. But we want to provide you with some statistics that we've found to show you that the work is worth it. It is worth it. And what we found through examining over almost 23,000 applications in our online application tracking system that we maintain is that the use of the SOAR critical components, including the medical summary report, statistically increases the likelihood of an approval and reduces the days to decision on initial application. We found, the 23,000 applications were tracked over the last 10 years. We found that applications with an MSR were more likely to be approved, and also having a co-signature on the MSR increased the approval rate by 13 percentage points. So that's pretty significant, and this was recently analyzed data, and we're really happy to be able to provide you with that to show you that the good work that SOAR practitioners across the country are doing by including all the SOAR critical components in the medical summary report is really paying off for those individuals that are experiencing homelessness. So with that, I'm going to wrap up my portion of the presentation and turn it back over to Kristen.
All right. Thank you so much, Dan. That was great. We really appreciate your perspective and hearing about your experience as well. So I'm going to turn things over to Jennifer Angton with the Nevada Bureau of Disability Adjudication to talk about MSRs from a Disability Determination Services perspective.
Thank you, Kristen, and thank you, Dan, for providing an excellent overview of the MSR and how it relates to the Social Security Disability Program and application process. You provided a lot of information that I think is essential to the disability application process. So some of the information that I am going to share may be duplicative of what Dan has shared, but I can go in a little bit more detail. So basically, I will be addressing the factors that are relevant to DDS. And if we go to the first slide, for the disability adjudicator, a well-written MSR should provide a brief summary of the claimant's medical impairments and how their impairments inhibit their ability to perform work-related tasks. The key components the DDS reviewer is considering in review of the MSR is the medical diagnosis and how it was established. We're looking for any treatment history that they have received, the type of treatment, and response to treatment. And we want to be able to answer the question how their conditions affect their ability to function. Next slide. The summary of evidence outlined in the MSR should be supported by the objective medical findings to include the signs and laboratory findings that establish the MDI or medical determinable impairment. Social Security defines signs as the anatomical, physiological, or psychological abnormalities that are observable, such as gait disturbance, limited mobility, abnormal behaviors and moods, deficits in memory or orientation. Laboratory findings are defined as one or more anatomical, physiological, or psychological phenomena that is evident in diagnostic testing, such as medical imaging, which would include X-rays, MRI, CAT scans, EEGs, ECGs, blood tests, and psychological testing. Next slide. In regards to the treatment history, the MSR should provide some details of past and current treatment, showing the longitudinal effects of the claimant's impairment. Reports of treatment should be relevant to the impairments alleged. Pertinent treatment history should include medications, mental and physical therapy, hospitalizations, frequent ER visits, and surgical intervention. Statements regarding the response to and or changes in treatment and side effects related to treatment can be useful in the reviewer's assessment as well. Next slide. As Dan mentioned, the functioning is a critical piece of the disability adjudication assessment. Functional information is a significant factor in assessing the severity of one's condition. Collateral information provided in the MSR is typically a true reflection of the claimant's limitations. What we have found in applicants' submission of the daily activity forms or the 3373 is that it's not always a true reflection of their limitations that they may have. Some of them will struggle with even knowing how to answer the questions, and they may have limited insight, so therefore they're not going to answer the questions accurately. So if we're not able to get collateral information from a family member or a friend, I do find that information provided by a caseworker, someone that is actually visiting with this claimant on a regular basis, and just based on their observations on how they're able to function, we find that to be a more accurate assessment of any limitations that they may have. Some of the key functional information to include for physical impairments would be difficulty in standing and walking for a length of time. In addition to that, if someone has to use like a cane or a walker, mentioning that if it's needed to even get up from a sitting position, if they need that assistive device to actually stand, or if they need it around the home, or if they need it just outside of the home, that is a good piece of information to include in that. If they have any weight restrictions in lifting and carrying, providing the specifics on that. If they can't lift more than 10 pounds, that's critical for us to know. And then indicating if there's any limitations in bending, stooping, or kneeling, that is helpful as well. Limitations in hand function, that would be decreased strength, if they have any weakness, difficulty in grasping things, if they have difficulty with their clothing items, zippers, buttons, picking up objects such as a coin, if they talk about dropping things frequently, not being able to hold things in their hand, if they have difficulty writing, that's helpful as well. How long does it take them to complete certain tasks, such as cooking and chores, or in this situation that may not be applicable to them if they are homeless and they don't, if that's not applicable to them, that's fine. You can just indicate that, or leave that information out and just indicate that they're not in a position at this time to do that. We take that in consideration, and that's not something that would be critical to that specific person. Next slide. The key functional information to include for mental impairments, as Dan mentioned before, some of the things that we're looking at is difficulty with attention and concentration. Do they need encouragement to complete tasks? And that could be their personal care, or even when you think about encouragement, do they even need encouragement to apply for services? They need to be encouraged to seek into certain programs, or you have to encourage them to seek treatment. That information would be helpful. Are they able to follow written and oral instructions? Think about if you're meeting with them and you're interviewing them, do you have to repeat the question or reword the question so that they're able to comprehend? Do you have to assist them if they're going to apply for services? Are you assisting them in completing, forms out? Do they have difficulty with getting along with others? Are they isolated? Has their condition affected their relationships as far as family, or did it affect their working relationships? And how do they respond to stress or changes in their environment? And that definitely can be, your observations or observations made by, a mental health provider. I've, seen where certain claimants may respond negatively if there has been a change in who is actually treating them, like a therapist. So those types of observations would be helpful to include as well. Next slide. How is the MSR beneficial to DDS? The MSR may assist the adjudicative team in determining the next appropriate action, leading to an expedient and accurate determination. If we have the MSR in file when we receive the application, that is definitely a good starting point for us. We are able to determine at that time if there is a lack of treatment, will we need to get an examination, and it provides us that story that we need, because when we're presenting the case, we're making our assessment and determining what that decision is going to be. In our writing, we're basically telling a story, so having that information up front gives us a head start on how to prepare that case and how to prepare that story particular to that claimant. The MSR can provide the supporting collateral information that is missing from the medical and non-medical findings. And again, the non-medical findings we do consider would be outside source statements such as the ADLs, a third-party ADL. A lot of times we'll look for information because we don't see them face-to-face. We're looking for any observational information that may have been done at the Social Security office. So when as a social worker or caseworker, when you're meeting with them, if they're, in their presentation, if they're just, disheveled, and if there's issues in regards to their hygiene or orientation, if you're able to provide statements regarding that, that gives us a better understanding of this person's presentation or how they're functioning, basically. And like I said, the MSR can provide a more accurate assessment of functioning. And one of the things that we're looking for are consistencies or inconsistencies. And a lot of times if we're looking at progress notes, if it's related to mental health, or we're looking at progress notes or medication review notes, a lot of times the information can be kind of cut and paste, and we don't get that accurate picture of how this person may be responding to medication. If they're progressing, they can give us one-word statements, or claim they're doing well or stable, but they may not make a statement regarding what their presentation is each time. So in that sense, we will find some inconsistencies. But if we have one person, such as a caseworker, who is able to, based on their observations and working with them, if they're able to provide that statement, that we will look at that statement as more credible than some of the information that may be missing, or some of the statements that may not seem correct in the medical evidence. And then just in closing, I do want to say I'm a supervisor now, but I have 17 years adjudicating claims, and I really think this is a great tool to use, and it's extremely helpful for the adjudicator, and I think it is a good tool to expedite the process.
All right. Thank you. Thank you, Jennifer. We really appreciate you taking the time, sharing your expertise, and really sharing the importance of the MSR to DDS. I want to take a little clip of your last few sentences there and play it for folks who are wavering on whether they think it might be worth the investment of time. So with that, I'm going to turn things over to Sean Kostick, the Client Financial Services Manager at Pittsburgh Mercy in Pittsburgh, Pennsylvania, to talk about winning MSR tips and tricks.
All right. Thank you, Kristen. Thank you, Jen. Thank you, Dan. I'd like to take a little different approach to things because we just got a lot of awesome technical information about kind of the technical side of how you're writing your MSR and what the adjudicators and the folks at DDS are going to look at in their process. What I'm going to try to do is supplement that a little bit, but also from the perspective of someone who's written multiple medical summary reports. Honestly, what are the approaches you need to take? What are things you need to look for? Not necessarily the process side, but like Kristen said, what are the winning tips? What are things that, how can you draw on your experience? Because we all got into social work for one reason or another. Probably not because we're mathematicians or accountants or engineers or scientists. We're really good with people. That's why we're in this field. So how do we leverage those skills that we have to build an MSR? Also knowing that we're good with people, we might not be Pulitzer Prize winning authors or writers or have the greatest writing skills. Your big takeaway, I want you to hear loud and clear, is that's okay. You don't need to be a strong technical writer to write a medical summary report. What I want to do is take a 30-second brain break from the technical side of a medical summary report. So we all work with people in some capacity. Think about a family member, a friend, a loved one, someone that you know really well, that you have a close relationship with, someone you know how they operate. And when you see their behavior, if it's out of the ordinary, you usually can diagnose what the trigger is. What did they experience, or what did something you say, or something you did, or something that led to that change? And think about, so in my case, I use my wife. When my wife gets quiet and she goes to bed early, I have to think back, and I'm like, oh gosh, what did I say in the last 20 minutes that she's perseverating on, okay? Because I know how she operates. So, and what makes that relationship so special is we're engaged with that person. So think about that before you get overwhelmed about needing to write an MSR. I really want to stress how important it is, the relationship you have with that person and how well engaged with that person you are, because that is going to aid you immensely. Anyone can sit down and collect medical records and pull stuff from there and put it in a report, but it's your level of engagement with that person to be able to elicit all the really, really useful functional information in their history that is going to supplement the medical portion of it. That's going to help, honestly, it's going to make the MSR write itself. So just think about that, okay, and then take a deep breath. Okay, so we all want to write an MSR. Congratulations, all right? Let's follow the rules. First thing, like I just said, don't get overwhelmed. Rule number 2 is refer back to rule number 1. Don't get overwhelmed. You can write this. Anyone can do it, whether you have a psychology degree, a math degree, high school diploma, GED, whatever. You can do this. And again, if you're still overwhelmed and you're writing it, an MSR is not going to hurt someone's claim, okay? It can only supplement the medical information that DDS is getting, okay? Only good things are going to happen. And I said before, many of us are caseworkers, not English majors, not journalism majors. So the other thing I want you to think about when you are sitting down to write an MSR, now that you're calm and prepared and you're not overwhelmed at all to put together a 6 or 7 page report, also keep in mind the person you're in front of, everyone's in a different situation. So lean on the engagement piece and your skills in engaging people and find out what makes the person you're working with, what makes their situation unique, and then highlight that. And also, I think it's also important, and one thing I learned listening to Jen talk is be aware of your blind spots. And what I mean by that is a lot of us might have a strong history in mental health, such as myself. And Dan, actually just learned that you have years working on an ACT team. I have the same experience, so I really appreciated you addressing that. But I think a lot about mental health symptoms. And when I see that I have folks that have a lot of physical health issues as well, it's almost, I don't want to say it's a deterrent, but I don't know that I even give that as strong of attention as I could, because I know I'm not as strong in that area. But when you listen to what Jen just said, that's really important. So know your blind spots. If you have someone else, another colleague who might know that area pretty well, don't be afraid to ask a question or two about it. Or if you have an adjudicator at DDS that you have a good relationship with, don't hesitate to give them a quick call and see if they can afford 5 minutes to explain how that might be useful or what would be important for them to know about that condition. So, okay. So real quickly, on the different sections, when we look at the personal history, like I said, I think the biggest mistake I made when writing MSRs throughout the years, especially my first few months, is I felt that I needed to give this extremely long, detailed narrative so the person knew every little detail about the individual I'm working with. And what I learned is less is more. To echo what Dan said, just include what's relevant. If their childhood and upbringing and family, if that's not relevant to their current condition and functional limitations, you don't need to include all that. If the person moved 15 times because they were in the military, but that's not related to their condition, you don't need to include all that. And again, touching on the physical health history, if it's unremarkable, if someone's healthy and they have no history of any medical procedures, surgeries, complications, any problems, one succinct sentence that says, John Smith's physical health history is unremarkable. That's all you need to put. Okay, diving into substance abuse, like I have there, be honest, I think this is the one section where, as a writer, if you're working with someone who has a substance abuse disorder, it can be a little intimidating, a little frightening, because your natural instinct is you don't want to share what might be damaging to their claim. But be honest, that's the one piece that if you try to cover something up, but it's in the medical records, your credibility is thrown out the window by doing that. So if you are working with someone who has a substance abuse disorder, first, again, document it, say it's there, but highlight what treatment this person received. Highlight periods when they're clean. And if this is someone who is frequently using or under the influence, highlight when you see them and they are not that way and when they are clean. And if you see a difference in functioning when they're clean working with you versus what's in the medical record, highlight that. One tip, though, if from working with that person and reading the medical records, if you're not able to determine that the substance use is not material, so if you can't tell a difference from if their functioning looks the same when they're clean and when they're, if it looks very different, and someone functions really, really well when they're clean and sober and they have a lot of symptoms when they're under the influence, if you can't prove that's immaterial, DDS is not going to be able to do that either. So you might want to have an honest evaluation of the person you're working with. That can be a really hard conversation to have, but education and that, engagement with that person is really going to help you there. So work history. What's super important I want to stress here. How many people do you know are really open and comfortable sharing things on the work that they're not good at, or things of the job that they struggled with, or reasons they were fired from a job? No one. No one wants to share that. So keep that in mind when you're authoring this section. And you have to be delicate. Tease out that information. Organically, we're going to be guarded about that, about why we lost a job or why we only stayed on the job for 2 months or 2 weeks or 2 days. And if someone is resistant or they're a little guarded about it, that's okay. Just, you can move on to another section. But again, that's where your engagement with the person is really going to be helpful. And if you are delicate enough and strategic in how you work with the person, they're going to come out and give you what happened in their side of the story. And what you might learn from that is really valuable what happened, and you might see that their insight into what happened might not be the same as what reality tells us. For instance, it's really common. I work with people and they say they had a supervisor or a coworker or coworkers who were out to get them, and they just had it out for them. And then you look and say, ding, 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 this person has an accompanying anxiety disorder. Well, yeah, it makes sense. It makes sense that you have difficult relationships with your coworkers. Lean on that when you do your work history section. But again, when you're interviewing a person, just be really open-ended. That's the best way to get the important details. And then in the functional areas, again, to me, this is the bread and butter. I mean, I think the medical summary report is the secret sauce of a SOAR application. And I think, to me, the functional areas are the bread and butter of your MSR. That is where you can really succinctly pull together those really nice examples. What are you seeing? And when I meet with folks for the first time, I tell them, I say, hey, when we meet, I'm going to ask you some questions. I'm going to take some stuff down. Don't be alarmed if I'm writing slow or I'm writing a lot of slow things down. I tell them, I said, I'm going to write a lot of quotes from you because the person that makes the medical decision on your claim is never going to meet you. I said, they're never going to see you. They might talk to you on the phone 1 or 2 times. I said, so part of my role is to be the eyes and ears of that person, to share with them things that your doctor might not have written in a note, or it might not be in a hospital record, or it might not be in a therapy note. I really want to give them as much evidence as possible on why working is difficult for you or why you're not able to work because of your condition. So, and again, that's part of engagement. I think I start off with that in my intakes with folks, and that really helps anxiety levels go down. Because normally, think about it, if you're meeting with your doctor or a professional and there's this period of silence because someone's taking notes, it gets a little off-putting, a little intimidating. But again, if you can tell them right off the bat, hey, this is why I'm doing it, I mean, sometimes people go the total opposite direction and they'll say, oh my goodness, I can give you so many quotes. Let me tell you about this. Let me tell you about this. Let me tell you about this time. And you really build a good relationship with the person that way. The other thing about the functional area that's so important is when you're working with someone and there's not a lot, then they might have very limited evidence, or maybe the evidence isn't that strong. Again, we're all in social work. We've all worked with people throughout the years that, from our observations, you kind of look at the person and you said, I know that this person, I just know that they would have a lot of trouble working, and I know there's a reason they can't work. And sometimes we're educated and we're able to pinpoint out those folks and why. But if it's not in a medical record, that's where the MSR really strengthens that. It's our opportunity to support that person and share all those reasons, those non-tangible reasons, to put it in writing and show a third party, hey, this and this and this and this and this. All these things are the reason this person can't work. These are all the symptoms the person faces. Because you also have to keep in mind when folks meet with doctors or therapists, there's naturally still a level of social desirability. There's things that you don't want to share, things you struggle with. But when you're working with your SOAR worker and you're just an open ear and someone has a good relationship with you, they're going to open up and tell you all sorts of things. So we're really in a really nice position to get a lot of that great detail. So, okay. What I'm going to dive into now is a few case studies. And this was difficult, narrowing it down to two. But I want to share with you two cases that really stood out to me and kind of the approach I took in writing their MSR and why I believe their MSR was so helpful. So the first case study, his name's David. At the time we worked together, he was a 27-year-old single white male. His diagnosis was major depressive disorder with generalized anxiety disorder / social phobia. But what's really important, he had a really, really, really limited treatment history. And when I say limited, I mean he had one crisis mobile team called to his home once in his adult life, one evaluation at an emergency room, and he was currently engaged in mobile mental health treatment. Mobile mental health is, in Pittsburgh, it's individual therapy. Only the individual therapist comes to the person's home once a week to do that therapy rather than be clinic-based. So it didn't have a lot to work with. What's also really important I want to point out is his medical summary report, since he did not have a treating psychiatrist, it was not signed by an acceptable medical source. So that's something else that was in play here. So I really had to rely on my observations, my engagement with this young man. And where we were fortunate is he lived with his sister. His sister was very supportive. They've lived together their entire lives, moved around a lot, and it was unbelievably helpful to have her there, because when this gentleman presented and I introduced myself, he put his head down, looked at the floor. He did not verbally respond to me. He limply extended his hand so I could shake it. When I would ask him questions, he would look at me and freeze up and immediately look at his sister and wait for her to respond to my question for him. That's how severe this man's anxiety was. When we learned more about the function information, turned out he'd worked twice in his life, but both times were due to nepotism. They were facilitated by family members. The one time he went to an interview because a family friend owned this garage that he was interviewing for, but he told me he locked up and would not respond to any questions that the gentleman asked him. The manager who owned the shop knew the family and decided to take a chance on him just because he knew the family. None of that's going to be in a medical record. So it was really important to get those stories and those really succinct examples from him and from his sister. More importantly, another thing he dealt with is he only left the house once a week with his sister to go to the grocery store. And they both said that he would just stay right by her side. He would have, if he went down an aisle and she were to say to him, hey, go down and get a can of black beans, he would go down the canned goods aisle and stand there. And if there were two different brands of black beans, the anxiety of choosing between the store brand and the Bush's brand would be too much for him to make a decision, and he would stay there until his sister came in and picked him up. So again, I know I'm hitting hard on engagement and observation, but it's so critically important. So getting back to the medical summary report on this guy, again, not a lot of medical evidence, but when I say it was heavy on observation examples, that's what I'm really, really was. But it turned out he was approved for SSDI in 54 days. No consultative examination was ordered for him. And they agreed with the alleged onset date that we put on the application and in the medical summary report and the supporting documentation. He ended up getting over $11,000 in retroactive benefits. So that's a case that stands out that I really like. And I'm going to flip the other side. I'll be a little quicker with this gentleman. Gentleman's name was Keith. At the time we worked together, he was a 60-year-old single white male, also diagnosed with major depressive disorder, with incipient presenile dementia and severe alcohol use disorder, which was in remission. What was different with this gentleman is obviously he was much, much older. He also had a very long work history. Keith very proudly was a steel worker for 27 years, worked in the mills for the better part of 3 decades. And when he lost that position, he then went back to work as a security guard for 10 years. And that position ended in 2017 when he was hospitalized. So this gentleman worked for the better part of 4 decades. Finding out a little more information about his work history, when he worked as a security guard, he worked overnights. And he sat behind a desk in an office building downtown where no one else was there. And his job consisted of sitting behind the desk watching the monitor and rounding in the parking lot or parking garage once every few hours. So the first thing I pick up on there is he had no interaction with people whatsoever. prior to that, working at the mill, he shared with me, again, that's a lot of independent work, and he was very heavily using alcohol at that time. So again, he had symptoms, and he had symptoms that he was dealing with at that time, but he was coping using alcohol. So all this kind of goes into my, in the Rolodex of my brain, and how can I leverage that later down the line? So going back to January 17, I have on the note here, that's the first time he had an encounter with mental health treatment, was when he was 60 years old, after he worked for 37 years. So how the heck are we going to prove that this guy is permanently disabled if he has no treatment history? But it turned out between the symptoms we got, he had one inpatient hospitalization. The records were phenomenal. It turns out a family friend found him in his home. This gentleman, Keith, lived in the home of his deceased parents, so he had only ever lived in this home. Turned out that he had been laid off for 2 months. He had lost 40 pounds over the course of 2 months because he was not eating, and he was so depressed, his home was completely squalor. There was rotten food in the refrigerator. As I said before, lost tons of weight. His hygiene was horrible. So he was treated in the hospital on a 302, then had a step down at a diversion and acute stabilization unit, and that's when him and I met. And we worked together on his application. So in Keith's case, his MSR was signed by a treating physician, and he was also approved for SSDI benefits in 57 days, no consultative examination needed. And again, he had a very nice award amount of almost $1,900 a month. His first payment was 2 months post-approval because he had that 5-month waiting period. So I think in this case, they agreed with the January onset date, and his first payment came out in June of 2017. So, okay. So now that we're all warm and tingly from some case studies, I have probably 1,000 more I could share. Even when Dan was talking, I had 4 other examples I wanted to throw out there, but for the sake of time, I'll save them. But a couple important things. What's just as important as knowing what to include and what to look for when you interview people and what do you put in MSR are things you definitely don't want to do. Like I said before, don't jeopardize your credibility by giving an opinion or exaggerating. It's a report. It's not an editorial. It's not your opinion of somebody. It's what you can see and what you can prove. Also, what could be a rookie mistake, don't ask every question on the interview guide. I think there's at least 1 billion questions on there. If you want to save yourself from being overwhelmed, certainly don't do that. That's a really, really comprehensive guide, and there's a lot of great questions and great approaches to take, but it's not meant to be mandatory to ask all those questions. I said before, don't live out quotes. Quotes are insanely important. Also, as important as being succinct. Like I said before, when I first started writing MSRs, I was writing 10, 11, 12 pages. And the first section where I cut down was in the personal history, because I was writing 2 pages of personal history per medical summary report, and really I needed, a paragraph, maybe 2. So it was a lump I took when I started, but that's okay. And again, talked about don't try to be too technical. Having technical language and technical writing is not a replacement for content. Keep that in mind. Layman's terms are perfectly acceptable, and I'm sure you can ask an adjudicator, they're probably refreshing. After sitting down and reading medical terminology all day long, probably a layman report is pretty nice, a nice little break from things. And also, when you're sitting down to work on it, if you're stuck, we laugh about with my staff all the time is I'll have a staff, he'll leave his office, come into mine, and he'll say, Sean, I just wrote the same paragraph 7 times and deleted it over and over and over again. And I'm sure we've all been in that situation. If you're stuck, don't start at a blank screen. Just move on to a different section. If you're stuck on substance use history because the person is currently using and you don't know how to succinctly highlight sobriety, then go to the functional areas. Go to the personal history. Go anywhere but the substance abuse section that you're stuck on and been looking at for 30 minutes. Also, when you're writing, to complement what Dan said before, use your own writing style. There's no prescribed method that you have to sit down and follow when you're writing this. We all have different approaches. We all are comfortable in different ways. One thing I do is when I do an intake with someone and I know that they're going to be a good candidate, I immediately, upon finishing my intake, I open up an MSR and I hurry up and I blaze down as many quotes and observations as I can remember. Anything that's going to be helpful I write down because guess what? I'm probably going to forget it in 5 minutes. But when I open that MSR a week from now after I meet with them the second time, that's going to come back so quickly. And it's a really good opportunity just to keep all those things you see. Because, again, people present differently from time to time. Also, when you think about functioning, think about the persistence area. And if you have someone who is missing appointments with you, that you can tie that back to their ability to manage themselves and their persistence. If they are having difficulty keeping an appointment with you to help them get benefits, it's an apples-to-apples comparison on them being able to get to work, to make money, doing a job. So leverage anything you get. And okay, very quickly, just some things to remember. And again, I've pounded this home, and I'm sorry for being so repetitive, but when in doubt, focus on the person's functioning. If you look at someone and you think this person is going to have a lot of difficulty working, but it's not in the medical record, well, why? Observe it, write it down. Make sure the adjudicator knows that. Also, when in doubt, if you're more technical, refer to the Blue Book. It's very concrete. It lays out there. These are what we look for based on the condition or conditions you're claiming. I can't speak enough of what's available on the toolkit on the SOAR Works website. There are oodles and gobs and gobs and gobs of insanely helpful resources there, whether it's from the technical end or from example medical summary reports. And again, these aren't meant to be done in one sitting. So, when you're going to write, be in the right mental state to make sure you're clear-headed, make sure your schedule is clear and blocked off to write, make sure you're free of distractions. And if you get a half an hour in and you start hitting a brick wall, then know when to say when. Know when to sit down and say, okay, I'm going to pick this back up tomorrow or in 2 days from now when I'm thinking a little clearer. And again, I touched on this earlier. Make sure you talk to, if applicable, make sure you talk to person support, to their family members, because the amount of first-hand information they can share with you is so valuable. And you're not going to get that from a medical record. So, trying to think if there's anything else that's important. I know when Jennifer talked about a consultative examination, also keep in mind you might have the best MSR in the world, and you still might be called for a consultative examination. When you're there, though, keep in mind a lot of folks, especially with schizophrenia or psychotic disorder, their symptoms might not come out in 20 minutes or 30 minutes. So if you feel that you've been rushed at a consultative examination, I really recommend either trying to delay that exit, or if you were just inappropriately shoved out the door too quickly, call the adjudicator and let them know what happened. Very quickly, I had a gentleman I worked with who I timed from the minute he was called back from the waiting room until he was done with his consultative examination was 6 minutes. It is impossible to do a mental status examination based on the questions they have in front of them in 6 minutes. So I called the adjudicator. The adjudicator then referred me to the complaint department at DDS. The complaint management technician knew the examiner I was calling about before I even gave the person's name. And what ended up happening is they ordered another examination, took the gentleman to the examination. It was a different examiner, and he was approved benefits. So just a little tip, again, going back to functioning. So I am going to turn it back over to Kristen, our facilitator. I apologize if I spoke too quickly. I had a lot of things I wanted to want to share with you. But in case I wasn't clear enough, I'm the champion of functioning and observations when it comes to writing my medical summary reports. So thanks, everybody.
All right. Thank you so much, Sean. That was a fantastic presentation. We really appreciate hearing your experience and your tips. So I know a lot of folks will have some questions, and so we definitely have a lot of time left to address those. So if you haven't already, you can pose your question to the panelists now by typing into the Q&A panel on the right-hand side of your screen there. And we will kick things off with a question that came in for Sean, and for anyone else to jump in. How do you work with your staff to ensure quality MSRs?
Okay, thanks, Kristen. Great question. So again, one thing I said before is I do really support that people have different ways of managing their work and different writing styles. So the first thing I do, as tempting as it is when folks take the training course to try to jump in and give them tips, is I keep my doors shut and I shut my mouth and I let individuals' own learning styles take over. And then I read it when they're done. So I let the folks take their best their first draft at it, and then before they submit the first application, we meet and we go over the medical summary report together. And it's so much easier that way because it empowers the person to use their skills and their observations. And it's helpful that I don't know anything about the case except for the medical summary report in front of me. And then we use that just to coach what are some areas that look really good, what are some areas where we could probably cut out some detail, or what are some areas that would be helpful to supplement. Or it might be something as simple as make sure you cite your source here. So but that's an ongoing thing. Most folks I work with, after a couple medical summary reports, get pretty comfortable. The other thing I also have had some of my staff do is send their medical summary reports to the TA center because the gang there gives fantastic feedback. And I will admit, Chris, and I apologize, I do cheat and do that sometimes when I'm a little bogged down with extra work, but it's a great, great resource.
No apologies necessary. That's what we're here for. And thank you so much for reminding people about that resource. And I just want to say, like, as an addition to that, if you are interested in sending in your medical summary reports to the TA Center for review, just make sure you redact them for us. Do find and replace in your document and change out the person's name, delete their Social Security number and date of birth on the top so that you're not sharing any personal identifiable information. So we just want to read an anonymized report and give you feedback on it. All right, thanks. So the next question I think Jennifer can definitely speak to. So this provider is wondering, how far back do we go with the medical treatment history?
Okay, thanks, Kristen. It depends on if it's a concurrent claims, such as if they're applying for the SSD and SSI, onset is important. So we want to be sure that if they're, for instance, if their onset was in 2015, we will want to know if they were receiving treatment at that time, and we will request that information. If they had, typically if for the onset date, we would want to go back at least 1 year up to that onset date if there is medical evidence available. For SSI applications, it is typically 1 to 2 years. I suggest if you're speaking of a mental impairment, if they had received, if their hospitalizations were 10 years ago and they showed a period of stability based on treatment, or say, I would suggest providing that information because that gives us the history. If we have evidence that's showing now that they're stable, but for some reason maybe they had another psychotic break, or maybe their medications were no longer working, we would need something to show, okay, this is their history. If it's available, I would suggest providing that information. So at least the reviewer will have some knowledge of their history. I hope that answers the question.
Yeah, absolutely. Thank you. That's very helpful.
Okay.
All right. So our next question comes from Tony in Utah. We're wondering about any tips on getting medical records for people with no income, because medical records can be expensive.
Okay. Well,
so for any of our panelists too. Yeah, Jennifer, thanks.
Okay. If you're not able to get the medical records, of course, Social Security is going to request those records, and we would pay for the cost of obtaining those records. So in that situation, if an MSR would be helpful, at least to provide something with the application. If it's just the MSR and they're not able to get the medical records, indicating that it's helpful, and then, DDS will request the records.
And then just to piggyback off what Jen said, from the provider perspective, medical records departments usually have a negotiated Social Security rate, which is much, 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 much less than the first-party rate, usually around $28, $30. So it's a reduced rate, but what we always do is the TA Center in the toolbox has the very nice, succinct letter to medical records departments requesting that those fees are waived. So if you request those, if you're the representative, you request those records on the person's behalf, you can always negotiate with the provider to see if they'll waive those fees.
Yeah, and I can also just add, thank you, Jennifer and Sean, for your comments. This is Dan. Yeah, I've had a few occasions where I've gone to request medical records for individuals, and the medical records department were trying to charge a fee, and usually it can be really simply resolved by just calling the medical records office and either talking to a manager or even the person that's processing their request. And if you explain that the individual is homeless and has zero income, more often than not, I've been able to get those records, the fees waived. So it's just another layer of advocacy that you're able to provide for the individual that you're helping with the application.
Thank you all. And I have just one more thing I'll add. Is that it's different in every state, but there are a number of states that have laws that regulate the costs that can be charged for obtaining medical records. And so in some states, individuals who have low income or can't afford it, or individuals who are applying for disability, those fees are waived. And they're not always waived across the board, and medical records departments need to be reminded of the law in their particular state. So if you want to check with us at the SOAR Case Center about what those laws might be in your state, we can let you know. Yeah. So excellent. So the next question that came in, this is kind of a combination of a few questions, is should I still write an MSR even if it isn't co-signed by a doctor?
Yes. Absolutely, 1,000 times yes. Refer back to the first case study, the young gentleman I worked with who wasn't even seeing a treating physician at the time. Without the MSR, I have no doubt he would have been denied. There's so much useful information in an MSR for adjudicators to rely on. And obviously Jennifer can speak more to this as well. But yes, yes, always yes.
Yes, definitely. I've actually had this conversation with a couple of the adjudicators here. If it is not signed by an AMS, we still consider it evidence. And again, it can be critical in a case in that it's based on your observations, it's based on your interactions, and again, if you are working with, the family members or whatever, and they've provided you some information, it is definitely helpful, and it is evidence that we look at, we read it, we make note of it, and we consider it.
All right, fantastic. So there were some follow-up questions about what is an acceptable medical source. So physicians, psychiatrists, psychologists, advanced practice, registered nurses, and physician's assistants are all acceptable medical sources for that diagnostic purpose. However, like we've heard from all of our panelists, anyone can write a medical summary report, and it's absolutely still important evidence that's considered. So thank you all for that and for those questions related to that. So we also have a question about how to get medical professionals to sign off if they are afraid of liability issues. So kind of talking to and collaborating with an acceptable medical source in order to get them to co-sign the MSR. Strategies for that?
When I approach a prescriber or an acceptable medical source about this, what I always do is the first thing I say is, this doesn't hold you liable for anything. What you're agreeing to by signing off on this is that a review of the individual's case was done, and you generally agree with everything that is written in that report. There's no liability. We're not asking for an opinion on if you feel this person can work or not. So I try to nip that as the very first thing I say to someone before I ask them to read it and sign off on it.
And I can just add to what Sean said that there's been a few occasions where I've been assisting an individual with an outside psychiatrist that claims, usually I was fortunate that we did have a psychiatrist in-house, so it wasn't really an issue having them sign off on it, but I did assist a few individuals that had outside psychiatrists and doctors, and sometimes they expressed some hesitation signing the medical summary report on the first visit because they didn't have any longitudinal contact with the individual. So I would, if the person was okay with it, I would go to their doctor's appointments with them, sit in the examination and explain to the doctor exactly what I was trying to do to help the individual with the application, and then see if they were a little more comfortable with me taking the person to like subsequent appointments, maybe 2 or 3 additional appointments, follow-up appointments. And then after they were able to see the person, a little bit more and talk to them about their symptoms and their diagnosis, they were more willing to sign off on the medical summary report. And like Sean said, agree with the information that I wrote in there. So that would be another tip I would suggest.
Yeah, thank you both. I'll just add one more thing and also add a link to the chat box so people can access it. We have a resource on the SOAR website called What Medical Providers Need to Know About SOAR and the Medical Summary Report. And it helps to just kind of explain what are SSI and SSDI, who's eligible, what is SOAR, what is this that we're asking you to look at and review. So that can be a helpful tool for folks as well. All right, our next question is, have you ever shown a completed MSR to an applicant? And if so, how did you do that?
I haven't, no.
Yeah, I haven't either. I've worked with a few individuals that have asked to see their medical records that I help them collect, and sometimes what I would do is just kind of write a summary of all the medical records, but obviously people have a right to their records if they want it. I've never actually shown an individual that I've helped with a SOAR application their medical summary report either.
Yeah, and also to piggyback on what Dan said, same thing. I've had folks ask me for copies of their records that I've collected as part of their application. That is a big HIPAA no-no because they were released to us for an explicit purpose of applying for benefits. We're not permitted to re-release them for any purpose, except to Social Security as part of their application, but we're not permitted to give copies of someone's records to themselves. If they want them, they would need to follow the same protocol and request them for themselves.
All right, great. Thanks for that advice. All right, this next question is about kind of information to include in the medical summary report. So this individual is wondering if an applicant doesn't remember the dates and names of employment or their employers, is it okay to include any information in the medical summary report about their employment history?
I can take a stab at that question.
Yeah, great. Yeah, thanks.
And we require a 15-year work history, and I know that can be challenging for some. So if they haven't had any type of work history in the last 15 years, a statement regarding that is fine. If they've had a sporadic work history, if they've done just temporary type of assignments, they can indicate that if it was part-time. And then that way we can determine whether or not we need to investigate it further when it comes down to a decision, because we are able to run a query to see if they had earnings that were at SGA within the last 15 years. So if there is a job that, for instance, they provided on the 3369 that is unclear to us if it was at SGA, then we can look at that query to see the earnings that they received. So again, we're only looking at if they worked full-time, if it was at SGA in the last 15 years. If they only worked a couple of weeks at a time, we don't need that information. If they've worked for various temporary agencies, you can indicate a statement like that, just indicating maybe they worked 2 to 3 weeks at a time and maybe didn't work for another 2 or 3 months. But we're only concerned about any type of full-time employment performed in the last 15 years. If they don't have to have concise dates, maybe they can just remember the years that they worked. And what's important to us is the actual requirements of that job. So, if the physical requirements, any type of, if it was a customer service related job, interactions that they had, that's really what's important to us.
And Jennifer, this is Dan. I actually have just a follow-up question for you that I think would be helpful for participants, and it's a question that I get a lot from the field. What if an individual that you're helping with an application is reporting that they worked full-time for a number of years, but it was an under-the-table job? How should SOAR case managers address that in the employment history section?
The same way. If it was, you would consider their earnings. So if they were paid less than SGA, then you would indicate that. We're able to look at self-employed earnings if they've reported it, if they've applied for tax, file for taxes. That's the only way we can verify it through, the Social Security system. But we do get people that have worked under the table, and a lot of times it's not SGA. So you would still just want to know, okay, what did you earn? Were you, if you were paid $100, $200 a week, depending on the year, it may not have been SGA, and so it wouldn't be applicable. But a statement regarding that is fine.
Great, thank you.
You're welcome.
All right, so this next question is kind of about process. So how do you manage the time, waiting for medical records, reviewing them, interviewing, writing it, getting in touch with the provider to sign, all within the 2-month slot, so the 60 days for application submission?
Well, I can jump in quickly on that. Keep in mind the 60-day application time frame doesn't start until you protect the filing date. So you can have your intake send out for all the records, and there's going to be a delay waiting for those records to come in. And once you review the records and you feel that it's going to be a case you'll move forward with, at that time you can protect the filing date, and your 60 days starts there. And that's a lot of times, a lot of the wait is just waiting for records to come in. After that, things can move along pretty quickly, depending on just how you manage your own tasks, your own work.
And I could also add to what Sean said, and I agree with what he shared. And also, if your process is that you're gonna set the protective filing date right from the start, and then you're gonna request the medical records right away and write the medical summary report within that 60-day period, what you can do is that you can make sure that the medical summary report is moving along, and then you can also like if the medical records, if some of them haven't come in within that 60-day period, hopefully they will. Usually I think the most it would take would be 30 to 40 days is what it took for me for some treatment sources. But if all of them haven't come in, you can just make sure you're communicating with the DDS adjudicator that your case gets assigned to, and just let them know that you're going to be submitting X, Y, and Z treatment sources, and then this additional one you haven't received yet, but if it does come in before they get it, you'll send it over to them. So that's usually how I would handle that.
Yeah, and also keep in mind with the time frames that the application doesn't instantaneously go to DDS when you submit it to the field office. So your MSR doesn't need to be complete at the time that you submit the application. It's cheating a little bit, but if you know it's going to be done shortly after, you usually have a little bit of time from the time you submit the app until it's at an adjudicator's desk.
And I would suggest if you have not been able to submit the MSR once it's been assigned to an adjudicator, just providing the functioning information would be extremely helpful. And again, because that's based on your observations or observations from family members or friends that can provide that insight. I think submitting that information alone would be extremely helpful, even if you have not an opportunity to review all of the records or have someone to be able to sign off on that. But just a summary of basically of where they are currently, as far as functioning and what's in store. If you're planning, if they have pending appointments or something like that, to let us know. Or again, just even provide the history if they've had treatment in the past. And you haven't been able to request those records, but it still gives us some insight into that claimant.
Great. Thank you all. So we have just a few minutes left. I wanted to give our panelists an opportunity for kind of any last words or bits of advice that you want to share before we close out for the afternoon.
Yeah, I can share. This is Dan. Go ahead, Sean. You go first.
Okay, thanks.
Oh yeah. Well, I was just thinking when Sean was sharing his story, his success stories, that I meant to share this during my portion of the presentation. But I recently was working with a SOAR provider. She's a SOAR trained case manager in Northern California, and she works for a mental health agency. However, she was actually helping her son, who has a combination of physical and mental health conditions, and a lot of functional impairments, really severe physical illnesses in addition to his mental health conditions. And she was helping him with the SOAR application due to him being at risk of homelessness. And she sent me an email just last week saying that after she submitted the MSR to DDS, they got an approval back within a week. So she was just really happy. She also took advantage of sending in the medical summary report to the SOAR TA Center for review, which I think is a really good quality assurance measure in the beginning when you're getting going. Hers was really well written, so I didn't really have to provide her with much feedback, but it was just another success story that I kind of wanted to leave everyone with a little bit of hope in terms of writing medical and summary reports and submitting them as part of your SOAR applications. All right, John, all you.
Thanks. All right. Just two quick thoughts. One is, especially if this is your first time that you want to sit down and write an MSR, I can't stress enough, just don't get overwhelmed. I mean, we can all write them. Again, it isn't a technical report. You know, and if you need to be recentered, I mean, if you're spinning your wheels, take a break. Either step away from your desk or go to a different section, or just ground yourself. And again, think about if you were writing this report for your mother or your father or your child. And that really helps, at least for me, it really helps focus on what's functional, what's relevant, and what's really important to include. If you're able to focus that way, it really helps. I found it really helps me focus, and it almost writes itself. I think with the observations, one thing I don't think I highlighted was make sure you're specific in what you see. I would really avoid general statements that, you know, this person has difficulty doing tasks around the house, or this person has bad hygiene. Well, what does that look like? And that's something that can be addressed in the very first paragraph. You know, Mr. John Smith presents wearing soiled clothes, extremely malodorous, has matted hair underneath a baseball cap, has a beard with food debris in it, has shoes with holes in it, has fingernails that are approximately an inch in length and are yellowed. That helps the person actually see what the person's looking like, and it's a lot more clear than someone doesn't have good hygiene. So I know I hammered home, give examples, but give specific examples. It really helps. It really helps the imagery when you're writing.
One of the things that I wanted to mention earlier was regarding, and I think Dan talked about a little bit, the side effects of medications. It would be, you know, it's a good practice to make statements regarding that. Because what we'll see sometimes is someone's taking pain medications as well as medications for a mental disorder. The side effects alone of the medication can be limiting, you know, their functioning. If they're heavily sedated or fatigued, sometimes it's impossible for them to even get through a normal workday because the medications required for them to be asymptomatic is so heavy. So, you know, consider that as well. And another thing that I think people miss is that, like, we'll discover a condition within the medical evidence that is clearly disabling, but it wasn't shared. So think about that as well. If there's mental and physical conditions that this claimant may have, please inform us. Or, you know, if they reach, because what we'll see is sometimes, especially with the SOAR claims, the mental history, and it's just a focus on that. And then they could have some severe physical conditions that were not mentioned. So just remember those things as well.
Excellent. All right. Thank you so much to our fantastic panelists. We are out of time. If we didn't get to your question, we'll pose your unanswered questions to the panelists, and we'll follow up with you with that. So please take a moment to complete the evaluation, which you'll see upon exiting the webinar, and your responses will help to inform future webinar topics. So again, on behalf of the SAMHSA SOAR TA Center, we'd like to thank again our presenters and everyone who joined today's important webinar. And don't hesitate to contact us anytime for more support with writing MSRs. And have a great rest of your day. Thanks, everyone.
Thank you.